Welcome to Partners in Pancreatic Cancer. My name is Koushik and I'm in the Division of Gastroenterology at the University of Pennsylvania. I'm frequently asked, are screening tests for pancreatic cancer for the general public likely to be coming soon? And how close are we to finding predictive biomarkers for pancreatic cancer? Most of the common screening tests we think of for cancers in the general population are things like mammograms for breast cancer, colonoscopies for colorectal cancer, or PSA tests for prostate cancer. The incidence of breast or prostate cancer is approximately 130 to 140 per 100,000 people in the population. Meanwhile, colorectal cancer has fallen significantly thanks to effective screening programs from about 55 to about 35 per 100,000. In comparison, pancreatic cancer is still luckily quite rare at 12 to 14 per 100,000. What this means is that amongst the general population, we are effectively looking for a needle in a haystack. Also, even if we were to find something early, our best tool that we have consists of a relatively radical surgery to remove the pancreas, which, while life-saving, has many important life-changing side effects. As such, we would need to have a test with near 100% sensitivity and 100% specificity to use on a general population basis to look for something that has such a relative infrequency. This would be the only way we could screen the population to avoid detecting a lot of false positives, which may lead to unnecessary and complicated surgeries. As this bar is quite so high, given the low incidence of pancreatic cancer in the general population, it's unlikely that we'll find a magic silver bullet that we could perform at the populational level. That having been said, there are several interesting biomarkers that are currently in use, have been investigated, and that should be coming online in the future that are worth mention. CA19-9, the sialylated Lewis blood group antigen, is widely used in clinical practice, but its use is really limited to monitoring response to therapy and not as a diagnostic marker given its overall poor sensitivity and specificity. False positives are common with CA19-9 in patients with benign pancreatic biliary disorders, or certainly those presenting with obstructive jaundice. 5 to 10% of patients don't express Lewis antigens and don't have detectable CA19-9 levels as a result. Also, it's elevated only about 65% of patients with resectable pancreatic cancer. And this technique cannot discern patients with chronic pancreatitis from those with pancreatic cancer, as about 40% of patients with chronic pancreatitis have elevated CA19-9 levels. MUC1 carbohydrate antigen and the related PAM4 antibody have been investigated but have not been proven to be helpful. There was a lot of interest in mesothelin, a protein that has an elevated expression level in pancreatic cancer tissues, but not in normal pancreas cancer. And ELISA has been developed to look for circulating levels in ovarian cancer. This continues to be an area of investigation in pancreas cancer. And actually, this differential expression of mesothelin is being utilized as a potential target of immunotherapy by Dr. Carl June here at the University of Pennsylvania, but it still remains highly investigational. Other approaches like proteomics have also been utilized to try and find a clear answer, but have yet to find a clear winner. There are two future technologies that are coming online that I would like to mention. The first is circulating tumor cells. Dr. Andy Rim and Dr. Ben Stanger here at Penn first demonstrated the possibility of evaluating for circulating pancreatic cancer cells in a mouse model of pancreatic cancer. In an elegant paper from Cell in 2012, they showed that in approximately half of lineage-labeled mice with no apparent pancreatic ductal adenocarcinoma, but only pre-neoplastic lesions, that is, Pannin lesions, there were already single-cell liver metastasis present and circulating pancreatic cells in the bloodstream of the animals. This relatively startling finding opened the doors to the possibility that transition from an epithelial to mesenchymal state and the dissemination of cells into the periphery may actually be an early event in pancreatic ductal adenocarcinoma, which somewhat jives with what we see in the clinic. That is, patients present primarily with quite advanced disease, and furthermore, many patients blossom metastases that are not clearly evident preoperatively, certainly on imaging, in the postoperative period. Subsequently, work by Dr. Rim and Dr. Stanger have tried to translate these findings into human patients to see if this observation of circulating tumor cells is something that can be seen in at-risk populations. In a more recent paper in gastroenterology from last year, they looked at patients with cystic lesions of the pancreas, and about a third of those patients had identifiable circulating pancreatic cells. In the same study, they found that a majority of pancreatic ductal adenocarcinoma patients also had circulating tumor cells, and in comparison to control patients who were undergoing screening colonoscopies that had no noticeable circulating cells. This is very exciting, as the technique may be a means to identify those individuals with lesions that have dissemination potential and may in fact be the ones we should be focusing our attention on. However, the limitation is that this is still very early in understanding the biology of circulating tumor cells, as we don't know what having these cells actually means. We don't know if in those 1/3 of patients with cystic lesions of the pancreas, the presence of circulating cells actually correlates to any pathophysiologic process. For that matter, we don't know whether or not someone can go on having a few circulating cells in the periphery for years without any sort of meaningful risk of disease progression or occurrence for that matter. And we don't really know how many is too many to have in the periphery. Thus, we are very early in this field of circulating tumor cell biology, but it's very exciting, and I hope that it becomes online in the near future. The other technology to mention is circulating tumor DNA, or ctDNA. This has primarily been pioneered at Johns Hopkins by Luis Diaz and others. In several different epithelial cancer types and non-epithelial cancer types, researchers have investigated for the presence of ctDNA. Dr. Diaz recently published some of this data in Science Translational Medicine last year, and essentially found that nearly 100% of patients with bladder, colorectal, and gastroesophageal cancers had detectable ctDNA levels. In patients with pancreatic cancer, non-metastatic tumors had ctDNA detectable in about 48% of tumors, whereas metastatic patients with widely spread tumors had a much higher percentage of circulating tumor DNA. The biggest possible benefit of this technology may be amongst patients who are actually post-operative. Extrapolating from data from the colorectal population, these researchers found in that population that undetectable ctDNA was 100% sensitive and specific for recurrence-free survival. This would be a great technology to be able to utilize in our pancreatic cancer patients, and it always remains a question after a patient undergoes a Whipple surgery as to whether or not they will recur. There's also hope that ctDNA can serve as a liquid biopsy of sorts, identifying actual mutations non-invasively, such as those that may trigger chemotherapy resistance, such as in gemcitabine. I think overall the circulating tumor DNA will probably not be useful for the general population, as it is of limited sensitivity in patients who even have localized pancreatic cancer, but it may definitely have a role in patients with metastatic disease, or particularly those who are being treated and may need to be monitored while on treatment. Thank you for viewing this activity. For additional resources, please view the other educational activities on partnersinpancreaticcancer.com.